Continuing with chapter 27, our primary assessment. So we want to make sure that we just take a really good look at the airway, especially with face and neck trauma. We could have huge issues. If the patient's unresponsive, has a significantly altered level of consciousness, we may need to put in an appropriately sized oropharyngeal airway. We might want to be a little more cautious about using an NPA on somebody that has facial trauma. Just if they have a break in their nose, there is a small possibility that you can actually drive that into their brain. So just maybe think about that. We don't want to somehow restrict the chest wall motion because that's not going to help them. We used to, back in the day, put a big bulky dressing on like a rib fracture and put a ace bandage over that really tight. We don't do that anymore. For circulation, we're checking pulse rate, quality, regularity, and then again, making sure that we didn't miss any significant bleeding because that can just as easily get soaked up by the clothes and you just don't quite realize it. And then our transport decision, if they have airway, breathing, or bleeding type issues, they need rapid transport, and you might want to consider ALS. Stabilization, maintenance of an airway and breathing can be very difficult with patients that have a face or neck injury. Patient with internal bleeding, obviously we're not going to do anything for them in the field really. It's going to be more getting them to the hospital so that they can undergo surgery. We want to keep up reassessing to make sure that we're not starting to see signs of hypoperfusion. Any patient that has a significant MOI, even if they appear to be completely stable, should be transported just in case. They may have an injury that's causing a slow enough bleed that we don't pick it up right away. So we just need to be a little more vigilant about trying to convince those patients to be transported. Then even if the patient has no signs of hypoperfusion or other life-threatening injury, there always is the possibility of eye injuries, and they may not realize it. Anybody that has a decent blow to the head or neck or the face should definitely increase your suspicion of either a spinal or brain injury. For history taking, there's not a whole lot different here than anything else. You might want to be particularly aware of injury-specific signs and symptoms. If they have no pain and you think they should have some pain, you may need to do a little bit closer inspection of loss of sensation. Try and get plenty of information from bystanders and family members if at all possible. Gather a sample history. Physical exams need to be pretty thorough, especially if your patient is unconscious, because they're not going to be able to tell you where they hurt or what's going on with them. So we want to make sure that we start at the head and go down to the toe and do that 90 seconds. And then if we can get the time in the back of the rig to go through a little bit slower just to make sure that we didn't miss anything. We don't want to delay transport to complete that thorough physical exam. That's secondary. We can do that in the rig if we have the availability of getting to it. If a patient is responsive and their complaints are very isolated, you may want to consider just focusing on that area, but make sure that if they have an MOI that's significant with more than just that trauma, that you do a quick once over just to make sure you're not missing anything. Those really gruesome, super painful things can definitely be a distraction from something that is more severe, more life-threatening, but it's not as visually accessible to the patient. And so they focus on the severely angulated arm or leg or bleeding out of their bicep or whatever, and they completely have no idea that they're bleeding internally. You want to make sure that you control bleeding. In that first once over, we're not going to control anything bleeding, fracture, whatever, that's not life threatening. You're just going to keep an eye on it, know that it's there. And when you go back through your secondary assessment and have time to really spend on that physical assessment, then we'll go ahead and start stabilizing, looking for wounds that we can bandage. You want to use both hands and eyes. With the gloves on, it's kind of hard to feel the patient sometimes. So as you're checking that head to toe, make sure that you're continuing to pull your gloves out and take a look for any sort of blood that may be on them. If your patient's responsive, make sure that you keep them informed as to what you're doing and what you're looking for. You want to assess all the underlying symptoms or systems as well. Evaluate the eyes. Remember that visual acuity is considered a vital sign of the eye. Vital signs, you want to obtain a baseline early on in the call so you can make sure that you know if there's been changes. That also gives you a clue as to if there's unseen bleeding. So it's super important to get a baseline. For facial throat injuries, respiration, pulse is very important as well. And then your use of monitoring devices. We kind of tend to get super comfortable with these. Like I've talked about previously, you set the blood pressure to go off every 5 minutes and then you don't actually look up at it. We hate having beeping type machines in the back of the rig. So putting them on that pulse oximeter and letting it continuously monitor until it notices an issue and then it starts beeping at us. A lot of times we end up turning that beeping off, which is certainly not helpful. For your reassessment, repeat the primary, reassess your vital signs and your chief complaint, continue to reassess the adequacy of the airway, breathing and circulation, check any of your interventions, especially with somebody that has facial or neck injuries, because those injuries tend to affect more than one system. And you want to complete the vital signs about every 5 minutes. Interventions, you may start with spinal immobilization for any patient that has an MOI consistent with that. Maintain an open airway, be prepared to suction. Again, face injuries bleed pretty significantly. Consider an OPA in a patient that it's appropriate for. Whether you suspect significant bleeding or not, go ahead and give some high flow O2. If the patient has signs of hypoperfusion, treat very, very aggressively for shock and provide rapid transport. ALS intervention or intercept may be necessary. We're not going to delay transport on any patient who doesn't need to stay on scene very long. If they have severe injuries, they're shocky, they have airway compromise, we're not going to spend more time doing like physical assessments or non-life saving treatments in the field. We can do that all en route. For your documentation, include a description of the mechanism of injury, the position in which you found the patient, and like the car. Describe the car, if there's intrusion into the patient compartment, if the A-frames have collapsed and the roof is relatively smashed. You can paint that picture a little bit better so that the hospital knows what they're dealing with. For emergency medical care, you want to treat soft tissue injuries to the face and neck the same as anywhere else on the body. Assess ABCs, treat your life threats first and foremost. You want to make sure that you're following standard precautions because of the increased vascularity to the face and the neck, you may want to throw on some extra in the form of glasses and or a face mask. If there's not life-threatening bleeding, then we're going to open and maintain the airway. You may need to do frequent suctioning to remove any blood that's pooling in the back of the throat. Avoid moving neck patients when you suspect a cervical spine injury. We don't want to make that worse. Some patients have what we call a stable spinal fracture, and as long as you keep them still, it's not going to be an issue. But when you start moving them around, then it can become unstable and cause some pretty big damage. We're going to control bleeding by applying direct manual pressure with a dry sterile dressing if that's appropriate for your patient. So we can do, like, if a skull fracture is suspected, we're just going to wrap a dressing or gauze around the circumference of the head in order to hold a pressure dressing in place. We certainly don't want to apply excessive pressure if we think that the skull has been compromised. When an injury exposes the brain, eye, or other structures, cover those exposed parts with moist, sterile dressings. Apply ice locally to injuries that don't break the skin, because it certainly helps with the swelling. For soft tissue injuries around the mouth or in the cheek, make sure that you check for bleeding in the mouth, broken teeth, tongue lacerations. Tongues bleed a lot and certainly have the potential to obstruct the upper airway. Patients who swallow blood may actually hide how bad they're bleeding because it's going into their stomach and it's not somewhere that we can visually see it. But those patients that are swallowing blood, you're going to see it again because the stomach does not like blood. They will vomit at some point. We don't want to remove any avulsed skin. We've already talked about that. A lot of times the surgeons can stitch that right back into place. So if you find a portion of avulsed skin, wrap it in sterile dressing, place it in a plastic bag, and keep it cool. If the skin is still attached and there's like a loose flap, place the flap in the position where it's as normal as possible and secure it as best as you can. Sometimes we have to get pretty darn creative with how we bandage things because, I mean, the head is not really normal with an ear hanging off the side. I'm going to go ahead and stop here and then we'll finish off in the next video.